of altered bowel habits on and off from 2 years and history of weight loss. And on abdominal examination, it was non-significant. DRE and proctoscopy was unremarkable.
Thank you.
He's discharged in CCU.
Is he?
Oh, yeah.
But good.
Tomorrow. It's fine.
ये लाइफ कर
अभी वहाँ पे स्टार्ट नहीं हुआ
You happy?
You are missing me yesterday? Or not?
Missed you? You were going off to Medilink. You take him with me. He won't come.
अच्छा
He went to Medilink.
बैठ के पिक्चर दी वसीबे को
चलो दिखा दे
वसीबे को पिक्चर दी
Good man. So slow everything down. Slow everything down. All right. Ah. Right. So we've got some irritation low down. This could be proctitis. I never retrovert in this when we get people with this appearance because it could be scarring and it could be, you could easily traumatize the tissue. So we will be taking rectal biopsies. So slow down and advance. Slow down and advance. Slow down and advance. Good. Good. Slow down and advance. Slow down. When I say slow down, watch your hands. Your hands are doing this. Stop. Your hands should be doing this, not this. You're not going, hey, hey, hey. Ooh. Just above the dentate line. We could use lignocaine 2%. I'd have a go. I can do it tomorrow.
हाँ भाई ready
No. I would take biopsy of this.
चलो
Yeah, because this will have a focus of cancer. Because of the size. Yeah, possibly. But what we can do, what we'll do, do you use gastroscopes in so gastroscope? If you and I do it tomorrow, and then we'll talk through what we do.
Okay, that's good.
Yeah.
Would you like to have a look at it before?
No?
Do you think it will be taken out?
I believe whoever did this person's a good person. So I actually look at who does the test. If this name was different names, you know what I'm saying? If this name was, you know, somebody who I'd never heard of, I'd say yes, let's have a look. But when I recognise that the person knows what they're looking at, I then say fine, I take it on what they're saying.
No, I can be wrong as well. So
You can be wrong,
whatever it
but what I'm saying to you is what your interpretation of where it is, the size of it and all that needs to be believed. There are certain things that there are certain endoscopists who work in my department. I go, I want to have a look. Stop sucking. You're sucking too much. Slow down. You're still moving your hands too quick.
बिल्कुल आहिस्ता आहिस्ता
Shaista?
शाइस्ता
Shaista. Shaista.
she's आहिस्ता
Aista. Aista. And the next one, Sally. I know what that means. Yeah. Slowly. Saista.
Well, I'll be more comfortable if you just put a scope in and assess, because I don't want to call her again tomorrow and then tell her that cannot be done. She's here.
Because I then look at it and I think if she's here and I put the scope in, I might as well do it.
Okay. All right.
It's your choice.
Okay. It's better that we do it tomorrow because we'll not be pressed for time and everything.
And that will take probably about half an hour to do.
Half an hour.
Yeah. And all I'm thinking of is what do you, I'd be happy to do that today, demonstrate, but these guys, which you said, it's not appropriate.
Yeah.
And they'd want to see it, and they'd want to go back, and I've seen this, and I've seen that. So
Yeah. Okay.
it's up to you.
Yeah.
I mean, tomorrow we will do some therapy to it.
Yeah.
So even if it isn't, if we get to a point where we think, at least we've had a go, and then we can go for the surgical
That's
option.
good. That's good. Thanks for
Slow. Slow. Saista. Aista. How come I can understand when she tells me? Aista.
Aisa means slowly.
Slowly. Aista. Moro. Moro. Mo. Low. Molo. Moro. Molo. Aista. Molo. Ah. Rotate. Good. Don't leave. Don't leave, so you need to teach me more. This trip I've learned a lot. On previous trips, this is my first trip ever to Pakistan, yes.
what?
15. Stop. What can you hear?
Stop.
No, what else can you hear?
सुन रहे हो पेशेंट को पेन हो रहा है पेशेंट को पेन हो रहा है
Yeah. So what does that mean?
I inflate wrong.
No, you don't insufflate now. Which,
पेशेंट से पूछिए
अच्छा दर्द हो रहा है अम्मा
so what happens is people get so engrossed on the screen. There's a lot of things going off. Feet move, patient makes noise, and they get so engrossed that they don't even hear the patient making noises. Stop the procedure. What's causing the discomfort? Is it air? Is it that I'm actually causing too much pressure? Am I actually putting the scope in wrong? A lot of the time, him. See, he sucks, grabs the mucosa and goes forward. Stop sucking. You did suck. When you stand still. Right, when you suck, and this is the mucosa, this is what happens. You drag it and push it, and then it makes it difficult for the scope to go forward. Don't suck. Right. Stop. Right. Stop.
नहीं करो stuck नहीं करो
Stop. So, let go of the scope. Pop the scope down. Just for a second. Wait. No, 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 no. Ignore this.
उसको छोड़ देना
This is absolutely useless to you. Ignore it. If that meant something to you, you would have done something about what the shape is already. Okay?
I make a loop or
You are making a loop. That's an end loop. Ignore the end loop. Okay? So, what we need, get yourself some gauze. Gauze. Okay. Take the bung off. Put the gauze over the bung. No, just lightly, lightly. And drop that down. Finger away from the blow.
no, I'm
Yeah,
not.
that's it. That's good. No?
थोड़ा और ज़्यादा हो
Okay. So, what you've done, you've managed to get round really, really well. How many procedures have you done in total?
This is my fifth one.
No, that's your fifth one here.
Yeah.
How many procedures have you done in total? Be-
Total
bec-
14, 15.
Well, you said less than 10
Yeah.
when we started.
Yeah, but
Then
now
you
it's
said
total.
5. Now you're telling me
It's total
5.
15 now. This is, before I have done 10, this is my
Okay. Now, I'm only going to straighten the scope for you, only because the lady's uncomfortable. So what we've got, we took that off. If we look at the screen, this neutral, thumb here. So she's still uncomfortable, I can hear. So that's what you've got to be aware of. Listen to the patient. Looking, listening. So she was making that noise for a good 10 seconds. I heard it. I was waiting for you to pick up on it. Even though I was chatting to the ladies over there, I was still, my eyes were still coming back, wondering when you were going to do something. Okay? Look, that's what you've caused. That's what you've done. You did that. Okay. So blow water. When you get someone with colitis, so inflammation in the bowel, it's a very delicate bowel. So you've got to avoid doing what you're doing. You've got to be slow and you've got to take your time. I'm not putting any air in, but what I'm doing is he's trying to take your air out. Water. Can you see the water? See how far I got forward there, then I drawn back. Her bowel is sore. This would make for her to have a very uncomfortable procedure. Is she okay? Better? Water. See the water now? The water is going on to the bowel wall. See the scope? The scope now is just staying still. Little bit of suction. A little bit more. Keep the torque on. See this thumb? Pointing up at 12 o'clock. The thumb is at 12 o'clock. And then the scope goes forward. Draw back the scope. Let the scope go forward. So, thank you. Put the gel on the scope. Draw it back. The scope is very, very dry. Draw it back. Scope is very, very dry. So if you believe this, you're actually putting in an end loop. This is what you've done. End loop, if you believe it. So if you believe it, what you should be doing is clockwise torque and drawing back. Keeping the scope in a straight line, drawing back. Then you should go forward. Is she okay? Is she okay? Where? Okay. So what I do, I wait. So Uzma, she's talking to the patient. When you might not do this, this is what I do. I watch her when she's happy. Right? She looks a little bit more relaxed. When she's more relaxed, I know then that we can go forward. Slowly. She's, this lady's doing a valuable job. Very good job. Just let her, if she does her job correct, she'll tell you how to scope. Yeah? You're forming this loop again. What you're not doing is maintaining the torque. You're actually wanting to go in, right? Now, keep that torque on. Do not let that thumb move. I'm going to look at that thumb. If that thumbnail moves either direction, I know you're taking the torque off. Slowly advance the scope. You're moving it. Adjust the wheels. That's it. Now you can go forward. Good. Slowly advance. Right. So, stop. See where the thumbs ended up? Let me show you what I'm trying to get you to do. See where my thumb is? See where it's pointing? Keep your thumb. That stops the rotate, keeps the torque on. You're doing it again. Come here. Watch this thumb. Scope comes back. See the thumbnail? Do you see this number? Held. Do you see the scope? It goes forward. This is not rotating. I'm not doing this. You're doing this. Stop doing that. Because what it's doing, when you're doing this, it's allowing the scope to buckle. I'm watching your thumb. I know when you're doing it wrong. Now you're doing the same. I want to see this. Come back with the scope. Right, now hold that there. Now, see? Do not rotate this. Do not rotate. Good. Good. You see, you have to sometimes use the wheels. Now go forward. Now let the torque come in clockwise. Now you can do this. Is she okay?
Okay.
Finger away, finger away, finger away.
Okay. ठीक है.
ठीक है.
Okay.
Okay. ठीक है. ठीक है. Okay. Just stand there for a second. Right. So what we've got the scope. We're here. Bring it back. Keep it on a straight line. Keep it on a straight line. So what you've done, you've put a lot of air in again. See? And I kept the thumb. You've got to keep the thumb because it keeps the torque on. Slowly advance. Up at 12. Take some of the air down. Draw the scope back. Take some of the air down. Draw the scope back. Take some of the air down. Draw the scope back. Scope is staying still. The clockwise torque has been slowly applied. Keep the scope back. Finger is away. Can you see this finger? It's away. Now, any second, the scope now has done this, has moved. Yeah? Now, keep it there, and as you advance, you just neutralize this little wheel as you advance. Steer into the bowel, into here. So you're steering away. You come up. Yeah? As it goes forward, ever so slow. Slow. See how slow the scope is going in? So compared to you, how quick do you put the scope in? You're very quick. You're too quick. Is she uncomfortable? Okay. She's got way too much air. Bring her onto her back. Yes. Right. So you put too much air in, and I can't get the air down. How's she now? She okay now? Better? Not doing anything? One. Did she have any to start with? Yeah, how much did she have to start with? How much did she have at the beginning? Did she have? Yeah. Two. 1. Yeah. So you've got to allow that a couple of seconds to work.
लंबा लंबा सांस लो अभी सही हो जाएगा ठीक है बेहतर हुआ दर्द बेहतर हुआ
It's coming up to the hepatic. So he'd got round to the hepatic, but what he's done is overinsufflate, so it's actually caused the problem. What's he saying, Eric?
there's a pain why
Why?
pain
Too much air. Too much air. You air, it doesn't just dilate, it lengthens the bowel, right? So when it dilates and lengthens, the pain receptors aren't in the bowel. The pain receptors are in the mesentery that hold on to the bowel. You inflate it, you're stretching that. And in stretching that, it causes an awful lot of pain. So water. No. See, water. Water. Watch. Clockwise torque. Tip up. Anti-clockwise. Yeah? Man, slow down. Stop the button on the air. Draw back, clockwise torque. Suck. No, that's not. That's not. So, when I go, Eric will tell you. When, no, I'm here.
Yeah.
When I go, right, that's what you do. Listen, Eric will tell you.
ऐसे 2 दफा 3 दफा
Twice.
3 दफा
Yeah, and again. And again.
again
And again. And again. And again. And again. And one more. Good. See how much that air is in there. And again. Good. And again. Now ask her how comfortable she feels.
अब कैसी हैं आप?
Is she better? So the air caused the problem. No more. Go forward. Slowly. Slowly. No. No more. Go forward slowly. Remember the carpet. Clean your lens. See, you caught the mucosa now. See there now. That wasn't like that when we went round. No.
wash
Wash.
सफाई करो
No. Mild colitis.
कौन सफाई करो
Survival.
सफाई सफाई
Clean. Survival.
no
Secret.
सफाई
Suffi. Suffi. Suffi group. Can you see there to the left? Right. See there? That's the IC valve at 9 o'clock. Do you stop? Do you see at 12 o'clock? Try radiate fold. It's coming down. Now, as he goes forward, advance slowly. Now stop right in front of the IC valve, which is here on that image. You can see, no, the appendix. It's just there on this image. Okay? Now, if he does this, holds the scope, does this, man, stop being stiff. Big wheel forward. Now, tip up. Good. And you can see it. Can you see the appendix? Just there. Okay. So, what we need to do, this is colitis, not Crohn's. Right?
So, ulcerative colitis?
Yeah. It's not infective because there's no,
So not it's active colitis?
no, it's not very active. It's mild.
And which part extended or
Rectum, proctitis with patches, mild patches throughout. And we'll take some biopsies on the way
so
back.
it is pancolitis?
No, not as such. The colitis extends throughout the bowel, but it is not active.
Okay, so it's distal proctitis?
Yes.
Patchy all over the body.
That's right, yeah. Mild, patchy. So let's just get you into the... Right, so you're here. That's you again. Do you see this? You. Draw the scope back. See how much I have to take out on the air? I've just took the scope back. Right. Okay. Is she all right now?
Yeah.
So every time I give you the scope, she gets pain because you're putting too much air in. You need to stop putting too much air in. She gets a lot of discomfort. Take some biopsies, my friend.
I'm bed.
No, biopsies.
From here?
Throughout. Random biopsies. Okay. Rectum separate,
Right.
so random colon
Okay. Three bottle,
for one bottle, two bottle.
two bottle.
Right. Stop sucking. We now need to see the bowel. So come back with the scope. Come back. Come back. Now the sad fact is, you've caught the mucosa again. See there below us? That's what you're doing. You're strangling the mucosa, man. See it? Right. Biopsies. Oh, black coffee, yes, please. Slowly, slowly. Everything is slowly. Nothing is quick. Ish, ish. I'm thinking. Ah, you see, I'm thinking. Oh man, oh man, oh man. View of the colon. Your forceps cannot come out if we see the wall. You will actually push the forceps through the colon wall if you allow that to continue. Don't suck.
Hello, Dr. Paul. Can you hear us?
I can hear you.
Yeah, can we know they are taking biopsies from normal mucosa? What's the reason?
If you're in the room, you'd notice that it has got mild patchy engorgement in some of the vascular pattern. If the patient's got proctitis with a mild erythema throughout, so continue, keep coming back and take some biopsies.
Okay. So this is these are not the random biopsies to look for the dysplasia. If we are suspecting
No, man. If the biopsies is that when you're actually doing for colitis, the recommended practice is quadrantic biopsies every 10 centimeters.
Yeah.
If you're actually to do true dysplasia surveillance, you would actually need to do
64 or 32 biopsies.
well, 32 is what you actually normally end up doing to 36. But it's 62, ignore that, that's too much. And also, what I tend to do is, can you see there now at 9 o'clock? 9 o'clock.
Yeah.
Can you see the little patch of erythema?
Yeah.
So that's what I can see in the room.
Okay.
And so that might not stand out to you where you are. So there is these areas going through the bowel. This might mean that a more inflamed activity had been going on in the past, or that things have never got beyond this point. But what I'm doing is getting a baseline for the patient. But we will be taking rectal biopsies. But getting back to chromoendoscopy, that's what you should be doing if you're actually looking for proper dysplastic areas with colitis.
Which type of chromoendoscopy?
So I tend to use, where I'm doing it, I tend to use India ink straight into the water that we actually spray down the spray catheters or through the scope.
Does NBI helps in this?
NBI is crap because what NBI does, it actually if this stool left, do you see this stool that you can see there? That stool will be highlighted as red and it doesn't actually tell you a great deal. So what NBI does, narrow band imaging, it takes out one of the primary colours. So it's just looking for vascular activity. Vascular activity is just looking to see if an area has got more concentration of the blood supply to the area. It doesn't highlight areas of tissue of great interest. How it does enable you to look at polyps and does enable you to look at pit pattern. But in this country, I wouldn't get too worried about that. You're either going to take the polyp off or leave the polyp alone. If you've got a polyp, you need to take the polyp off. Now, come back to the rectum, my friend, and take biopsies. But don't retrovert. Run all that into the random ones. But don't retrovert. So the reason for not retroversion in the rectum is that you have scarring, you have a proctitis, you are going to traumatize the rectum. So don't take retrovert, but take biopsies. Hello?
Hello. Yeah.
Have we gone off?
So what's your take on eye scan of the Pentax? Is it
Eye scan is the same as MBI. Eye scan, again, is Pentax's version. Not Pentax, Fuji's version. Eye scan does work in certain circumstances. Now, if we actually are talking about Olympus versus Fujinon and versus Pentax, the scopes for the other two, Olympus I prefer. The scopes for the other two companies are not that good. Their response to torque steering is less than what you actually expect. So that's enough for that pot. So come back to the rectum. So if I was to say to you that when they say that you've got high definition from Olympus scopes, high definition for Olympus scopes is composite image embossed on composite image, and that then gives you a better definition.
okay?
Whereas when you look at Fujinon and Pentax scopes, high definition is true high definition. Stop now. Take some air down a little bit. More, 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 more. Great. Now take some biopsies as we come back.
Again,
We okay?
this?
Can you see the vascular pattern?
Yeah.
How it instead of being threaded.
Third bottle.
So where are we now?
This
Yeah,
vascular
this is
pattern
sigmoid.
here.
Third bottle.
Yeah. How many bottles have you done?
1, 2.
1, 2.
One is a alien.
No, we didn't do Turner Island.
Cecum.
Cecum, and then we've done random colon, and now this is sigmoid,
Yeah.
and then we'll do rectum.
Third, four
Four bottles.
This erythematous is
It's not erythematous. Can you see the vascular pattern to the right?
okay.
That's normalish. If you look to the vascular pattern to the left, you can see
And
that
what are this? This
that's
is
him. He calls that.
traumatic.
Yeah. Take your finger away from the air. Good. Now come back.
And what this red? This him.
That's him. Yeah. When you get a red linear line, that's a pressure from the scope as it goes through. Good. Now, if you look here on the screen, you can see that is normal. Take some air down. Good. Come back. Can you see there now? That's normal. So when you see that area that's directly in front, that's normal. Keep coming back. 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 Now, a little bit of air. A little bit. And keep coming back. Keep coming back. Keep going. Now, centralize your image anti-clockwise and come back. Keep coming. Keep coming. Keep coming. Good. Tip down. Keep coming. Now you want to take biopsies from here to the back. Back.
Can you tell me the biopsies where we are?
So cecum,
Okay. First,
random colon, sigmoid, and rectum.
Transverse colon.
Ascending, transverse, descending. And there, that's where you need to biopsy.
Is it third bottle?
This is your 4th bottle. You've done sigmoid. Get your finger off the blow.
नहीं होता कुछ.
Yeah. Okay. Now, tipple. Tipple. Suck. Tipple.
Biopsies for third is from rectum or sigmoid?
Sigmoid's the 3rd. Rectum. Suck. 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 That's it. No more.